Welcome to the InnoGuide podcast, where we share the works of authors and mentors to guide innovation. I'm your host, Bob Udelier. This podcast, my website, and my newsletter are focused on helping you discover the secrets of innovation in the age of AI. Since I don't rely on paid ads, I want to thank customers who bring me onto their programs as a technical product accelerator, working alongside their teams to help them develop products smarter and faster without adding risk while bringing human-centered AI skills into their organization. You can learn more at innoguide.net. In this episode, number 105, we'll be sharing Back Mechanic, The Secrets to a Healthy Spine Your Doctor Isn't Telling You by Stuart McGill. So I normally review books related to innovation, books that help innovators improve their results, simplify their work, make better decisions. And from that perspective, this week's book may seem a little out of place. But innovation can't happen in isolation from our health. Certain activities of daily living can gradually cause us harm and keep us from performing at our best. One of the most common is sitting. We sit too much, whether we're programming, attending meetings, answering emails, reviewing budgets, spending hours on phone calls. Most of us sit far more than we should. And one of the most common consequences is back pain. That's why I wanted to call attention to Back Mechanic by Stuart McGill. McGill is a widely respected authority on back pain and has worked with many, many difficult cases referred to him by physicians and other specialists. In this book, he explains how the spine works and why many common approaches fail, plus what you can do to prevent pain, reduce it, and protect your back over the long term. You may not need this book today, but someday when your back begins to complain, you may be glad that it's sitting on your shelf. It includes practical explanations, diagrams, self-assessments, and exercises that can help you better understand what is causing the problem and what to do about it. I hope you enjoy this overview. It's one of those books that truly belongs in everyone's personal library, not because we expect to need it now, but because most of it will need it eventually. So without further ado, let's get started. I first learned about Stuart McGill when he was on Peter Attia's podcast. And one of the things he said there, and he says in the book as well, is he rejects easy fixes. When urged to write 5 easy steps eliminating back pain as the book title, he refused. He said back pain requires science, not marketing. So who is Stuart McGill? McGill draws on 30-plus years of spine biomechanics research at the University of Waterloo, working with cadaver spines, pain patients, and elite athletes from UFC, NHL, NBA, NFL, and Olympic programs. He says working with elite athletes matters because driving a Ferrari teaches you what is possible. Their recoveries prove what's achievable, and he promises true causes, honest surgery guidance, and a step-by-step program backed by a 95% patient benefit rate. So, within this book, you'll find your step-by-step guide to getting your spine back in top condition. You'll learn these 5 things. 1, the distinct causes and progressions of back pain from disc bulges to sciatica. You'll also learn how the discs work and how they're constructed. 2, potential activities in your daily schedule that are causing and aggravating back pain. 3, healthy movement patterns that will promote pain-free living and allow you to continue to do the activities you always loved. 4, strategies and exercises to help you achieve and maintain a healthy and robust spine. 5, the mandatory checklist items for whether surgery will help or make the situation worse. This book is for everyone who wants their swagger back, from the homemaker who misses the spring in her step, wants to be able to walk the dog free of pain, to the former NFL player who is so plagued by chronic back pain that he can barely find the will to get out of bed. So let's get into it. He begins with myth busting. The medical establishment has failed back pain patients by perpetuating myths that prevent proper diagnosis and genuine recovery. When physicians spend only minutes with a patient and base conclusions solely on MRI or CT images, they're making a fundamental error, like diagnosing engine failure by looking at a photograph of a car. Even when a label like sciatica or disc bulge is applied, it rarely points anyone toward the actual healing. The real solution requires identifying the underlying cause of symptoms, not just naming the condition. One persistent myth claims pain is purely psychological, all in your head. This is wrong. Pain almost always has a physical cause, and psychotherapy as a primary treatment is misguided. While factors like job dissatisfaction can modulate how pain is perceived, they don't create it. Another myth suggests people eventually adapt to chronic pain. The opposite is true. Let's use a hammer analogy. Repeatedly hitting your thumb sensitizes it until even a light brush causes wincing. The solution isn't to push through it, it's to remove the hammer. Recovery begins by eliminating painful movements and gradually replacing them with pain-free ones. Surgery is not the logical next step when physical therapy fails. Surgeons sometimes remove healthy tissue, sever nerves, and weaken bone around metal hardware that's added, and patients frequently return within years with similar damage at adjacent sites. Insurance companies cite 6 to 12-week recovery windows based on rodent muscle studies, but human research shows true healing can take up to 10 years of careful loading management. Back pain isn't hereditary destiny either. Most people see their worst symptoms in their 30s and 40s, with natural movement by retirement as joints stiffen and reduce painful micromovements. And herniated discs don't end athletic careers. The author has successfully rehabilitated hundreds of athletes back to professional and Olympic competition. Several specific myths deserve closer examination. Tight hamstrings are typically a symptom of back problems, not a cause, and they often loosen as back pain resolves. Degenerative disc sounds alarming, but dark shading on an MRI simply reflects normal water loss in aging discs, comparable to facial wrinkles. However, if one disc appears significantly darker than the others, it likely reflects injury rather than aging. When left alone and not forced into an unnatural position, it naturally stiffens over time and the pain resolves. Bed rest is another culprit. Discs are hydrophilic. They absorb water when the spine is horizontal, causing swelling and morning stiffness. 8 hours is healthy, but extended rest allows continued swelling and increased disc pain. The problem with gym workouts isn't exercise itself, but poor spinal mechanics. Repeated spinal bending at the gym, combined with prolonged sitting and poorly executed daily tasks, creates cumulative disc trauma, while a sedentary person who never loads their spine that way experiences less disc aggravation. Changing default movement patterns allows people to enjoy fitness without compromising their backs. Yoga and Pilates are not universal solutions despite their reputation. Pilates in particular emphasizes flattening the spine and imprinting the lower back to the floor, deliberately disrupting neutral spine position and mimicking many patients' injury mechanisms. The roll-up, essentially an exaggerated sit-up rolling segmentally through each spinal joint, places unnecessary load on discs. The real goal is minimizing spinal movement and using the hips as the primary center of motion. Similarly, pulling the knees to the chest triggers a stretch reflex, providing only 15 to 20 minutes of temporary relief while aggravating discs, creating a cycle where patients believe stretching is helping when it's actually worsening their condition. Strength training is often prioritized because it's easiest to measure, but disproportionate strength without corresponding endurance causes further injury, like installing a 500 horsepower engine in a fragile car frame. Endurance for sustaining proper movement patterns must come first. Work hardening programs help some patients but harm others by imposing loads beyond their current capacity. Those who worsen are labeled non-compliant and excluded from outcome calculations, artificially inflating reported success rates. No single study and no universal cure applies to everyone. Controlled trials showing nothing works still contain valuable data. Some patients improved. Identifying what those responders had in common reveals which treatments match which conditions. The conclusion is direct and hopeful. If you've ever experienced even a single moment of pain-free movement, you can expand that into pain-free living. You are curable. Back to basics, getting to know your back and causes of pain. Most patients leave their doctor's office with either vague diagnoses like lower back pain paired with medication or confusing medical terminology, modic changes, spinal stenosis, degenerative disc disease. These provide no actionable understanding of the condition. The author's core grievance is that doctors fail to explain the basic injury and pain mechanisms that would actually guide a solution, whether from time pressure or genuine lack of training in back health. Understanding your spine requires abandoning the image of it as a freestanding pillar like Toronto's CN Tower. Think of it instead like a radio tower stabilized by guy wires. The surrounding muscles and ligaments function as those cables, those guy wires, providing both strength and mobility. Because bones don't create motion, muscles attached to bones do. A healthy spine displays three natural curves. The cervical spine curves inward, the thoracic curves outward, and the lumbar curves inward. The spine is strongest in this neutral position. Between vertebrae sit discs, not bones but spacers with tough outer collagen rings and a pressurized gel nucleus, functioning like a car tire to support the weight and enabling bending. Behind the discs sit facet joints that guide motion and support shear forces. The spine bends like a wire coat hanger. Bend one repeatedly and the metal fatigues and breaks. Your spine experiences the same cumulative damage. Repeated bending cracks the disc fibers, allowing the inner gel to seep through, a primary pain source, especially in people under 55. Paradoxically, thicker spines crack sooner because the bending stresses are higher. You can bend a thin willow branch far more than a thick one, which means exercises affect different body types differently. The solution is to bend at the hips rather than the spine. Hips are ball and socket joints, designed for bending. The spine is a flexible rod that becomes painful with repeated flexion. Torso muscles function fundamentally different than limb muscles. Limb muscles create motion, but torso muscles primarily stop motion. When walking, your leg cannot swing forward without a stiffened spine and pelvis for stability. The quadratus lumborum stiffens the torso without shortening or lengthening, fixing the pelvis so one leg can lift and swing. When opening a door, your hips and legs root into the ground while your torso muscles stiffen against the twisting tendency. Athletes who allow the spine to bend instead of using hip motion either injure their backs or limit performance, and the same applies to daily tasks. The abdominal wall's rectus abdominis anchors the obliques, forming hoops around the core that function as a spring, storing and recovering energy for throwing, kicking, jumping, and walking. Many people mistakenly train abdominal muscles like biceps, moving them through a range of motion. This is a significant and painful error. The core must stop motion, not create it. Stability comes from muscle stiffness, not strength. Think of a stack of oranges. Place a weight on top, and it crumbles. But stick toothpicks into the oranges and connect strings to the ground, and the stack stiffens and holds. This is how the spine actually works. That stiffness must be tuned to the task. Too much adds crushing loads. Too little allows painful joint movement. Endurance training must precede strength training. Contrary to popular belief, most back pain improves through spinal stiffening, not mobilizing. Mobility belongs at the shoulders and hips, not the spine, during load-bearing tasks. I'll say that again because that's key to preventing back pain. Mobility belongs at the shoulders and hips, not the spine, during load-bearing tasks. Load magnification explains why mechanics matter so much. Holding 5 pounds in your hand requires elbow flexors to contract with 75 pounds of force. A 50-pound object creates 750 pounds of joint force, close to half a ton. The spine experiences identical magnification. Bending forward with just body weight creates about 1/3 of a ton of force on spine joints. That's why keeping lifted objects close to the body and avoiding repeated and sustained postures is critical. 3 types of disc bulges each require different approaches. The first and most common is a focus bulge caused by repeatedly bending the spine away from the bulge's location, common in workers performing repetitive asymmetric movements. This type is dynamic. The right movement choices can actually shrink it. The cat-camel exercise, which moves the spine from rounded to arched on all fours, is safe because it involves minimal compressive load. Standing and bending forward to pick something up is not. It activates larger extensor muscles that compress the spine heavily. The second type results from a disc losing height, like a tire losing air, causing it to bulge on all sides. These are harder to shrink. The key is eliminating pain-causing activity and building pain-free habits. The third type is a disc tear caused by excessive twisting, where the nucleus gel gets worked into fissures between the collagen layers. Solution is straightforward. Stop twisting. Most people don't realize how often they twist unconsciously during tasks like unloading groceries. Degenerative disc disease is almost always a misdiagnosis. Loss of water content in discs occurs naturally with aging. It's not a disease. Paradoxically, as discs dry out, the spine naturally stiffens and discogenic pain often disappears on its own. Pain sensitivity works through a feedback loop. Repeated stressful loading sensitizes nerves so that pain triggers with progressively less stimulation, like picking a scab that never heals. The gate theory of pain explains how flooding sensory checkpoints with pain-free movement signals crowds out pain signals. Finding and repeating pain-free motions works the same way. Remove the provocative movements, and the pain sensors begin to desensitize while tissues heal. The degenerative cascade illustrates why spine injuries differ fundamentally from broken bones. A broken fibula heals stronger than before with no lasting consequences. A spine injury triggers a chain reaction. An end plate injury leads to disc bulge, flattened disc, narrowed joint space, trapped nerve root, and eventually arthritis developing over 2 years as new bone growth presses on nerves. Properly managed over approximately 10 years, pain can be controlled and eventually eliminated as the joint stiffens naturally. This chapter closes with a 9-point recovery framework. Identify and eliminate your pain cause. Increase awareness of pain-triggering movements. Develop replacement movement patterns. Stabilize the torso. Build a daily walking plan. Mobilize the hips. Generate power at ball and socket joints. Train movement patterns like push, pull, lift, carry, and lunge and squat. And make healthy spine choices during sleep, sitting, and demanding activity. Is surgery for you? The essential list. The central argument is direct. 95% of the challenging patients the author sees do not need surgery, even though many were told it was their only option. That conclusion comes from 3 decades of clinical experience tracking outcomes, including the failed backs left behind by unsuccessful procedures. One of the chapter's most striking observations concerns post-surgical rest. After surgery, patients recover quietly and gradually. In many cases, that enforced rest, not the surgery itself, is what reduces the pain. The implication of this is sobering. If those patients had simply rested and followed a progressive rehabilitation program without going under the knife, their results would likely have been the same. And surgery also carries permanent consequences. Nerves and muscles are cut, scar tissue can wrap around the nerves, causing chronic pain, and removed bone does not grow back. Even when surgery produces early improvement, patients who choose non-surgical options often reach comparable outcomes within a few years. The reason? Surgery addresses the symptom but not the underlying mechanical cause. Flawed movement patterns remain, and damage migrates to the spinal level above or below the operated site. To counter this, the author introduces virtual surgery. Before any rehabilitation, he asks patients to simulate surgical recovery. Complete rest, no gym, no stretching, followed by a slow, methodical program built around erasing pain triggers and establishing pain-free movement, walking, and targeted exercises. Many patients have outperformed the statistical outcome of actual surgery using just this approach alone. A typical cautionary story is this. A patient with episodic disc pain sees a family doctor, gets referred to a surgeon, improves during the waiting period, relapses after lifting groceries, then feels fine again, yet still gets nudged toward surgery. Episodic pain, with good days and bad days, is never a surgical case. It requires identifying and eliminating the triggers. Patients who had surgery after only 3 weeks of severe pain have been among the most disabled cases the author has seen. Surgery is generally warranted only when neurological deficits are severe, such as loss of bowel or bladder control, or in trauma cases. The chapter also warns against disc replacement. The artificial disc creates a rotation axis that rarely matches the natural disc, placing excess stress on adjacent facet joints, which then become arthritic over time. Closing message is clear. Arm yourself with information, ask tough questions, and take the steps required to become your own back mechanic. He calls the next section the Code, Rules, and Guidelines. This chapter presents 10 guidelines framed deliberately as adaptable principles rather than rigid rules, like the Pirates Code in the Pirates of the Caribbean, for avoiding future back pain, managing current pain, and building lasting back health. Guideline 1 calls for daily healthful movement until it becomes habit. 2, emphasizes balance across sleep, diet, and training. Neglect any element and you rob Peter to pay Paul. 3, targets posture. Identify movements and positions that cause pain and eliminate them. This is spine hygiene. What you don't do matters as much as what you do. Guidelines 4 and 5 address the healthcare system. Competent clinicians heal causes, not symptoms, and require fewer visits. Passive treatments like ultrasound, which has never outperformed placebo for back disorders, relieve symptoms without curing causes. Some passive approaches, such as chiropractic manipulation, can open a window of pain-free movement, but only when combined with active patient engagement. Guideline 6 reinforces that patients have every right to question clinicians. Surgery rarely succeeds if faulty movement patterns remain unchanged. Guideline 7 adds that leaving with only pain pills and no active plan means you didn't see a back expert. Numbed pain often allows harmful movement to continue. Guideline 8 warns against overemphasizing strength. Endurance and control are the necessary counterbalance. Guideline 9 rejects one-size-fits-all programs outlining 4 steps. Diagnose the cause, remove it, choose appropriate rehabilitation, then expand pain-free activity. And Guideline 10 closes with continuous reassessment. A patient who can walk 5 pain-free steps, but not 6, should walk 5 steps every hour, gradually building tolerance. Recovery is progressive, guided by honest reevaluation at every stage. So, next he talks about using the McGill approach to find your pain trigger. This is the clinical method Dr. McGill uses to identify the root cause of back pain and explains how readers can apply a version of it themselves. McGill's key observation is that injured people habitually move in ways that worsen their pain. His clinical success comes from identifying those flawed movement patterns and replacing them with pain-free alternatives. His process begins with pure observation. Before any formal examination, he diagnosed a patient's exact bulge at the 4th lumbar root simply by noticing a subtle right foot slap and compensatory hamstring activation, stunning the surgeon present. Pattern recognition and deductive reasoning, not technology, reveal the truth. His 2-stage plan first identifies pain-free alternative movements and then adds therapeutic exercises only after sensitivity decreases, avoiding the common mistake of jumping to resistance training before fragile tissues have healed. This chapter has many photos in it, pictures of what to do, what not to do, how to do them. So the book is key to understanding how to use his approach to find your pain trigger. The next section is your self-assessment. Foundation of back pain recovery is understanding that all pain has a specific cause. Poor movement patterns and postures create triggers that irritate painful tissues and make them increasingly sensitive over time. Your task is to identify and eliminate your personal triggers. While a detailed spine assessment requires expert diagnostic skills, most back pain sufferers can become their own best diagnosticians by systematically working through this chapter's progress. Rule out sinister causes first. Before beginning self-diagnosis, visit your primary care physician to rule out serious underlying conditions like tumors. Your doctor should review blood tests, unintentional weight changes, trauma history, bowel or bladder incontinence, cancer history, fever, progressive night pain, and saddle anesthesia. Sinister causes are rare, but when they exist, pain typically remains completely unresponsive to changes in spine motion, posture, or load, a clear signal to return to your physician for deeper investigation. What actually predicts pain? Traditional orthopedic exams, measuring range of motion, strength, and reflexes, don't identify pain causes. Research tracking pain clinic patients found that initial assessment scores didn't predict who improved. What actually matters is a different set of factors. Movement initiated from the spine rather than from the hips or shoulders, asymmetric strength and movement patterns, stiff hips, particularly one-sided stiffness, imbalanced torso, muscle endurance with back muscles weaker relative to abdominals, and pain with prolonged sitting or standing. Asymmetry between left and right sides carries more predictive power than tight hamstrings alone. The key is provocative pain testing, intentionally triggering pain to identify which postures, motions, and loads cause it, and which offer pain-free alternatives. Those alternatives allow you to desensitize painful tissues so what hurt last month becomes tolerable next month. Step 1. Make your lists. Write 2 lists, activities that increase your back pain and activities that don't. If sitting over 15 minutes, tying your shoes, and driving cause pain while walking doesn't, your trigger is a flexed spine posture, what the author calls flexion intolerance. If pain starts after 5 minutes of walking, but sitting or lying down relieves it, and you're over 55, you likely have spinal arthritis requiring a gradual walking progression. The essential questions: does your pain intensity change? Pain-free mornings or hours mean a reason exists, and understanding it guarantees success. Do you experience painful catches when rolling over in bed or painful stabs when sneezing? This suggests spinal instability. Stabilization exercises prevent the micromotions that trigger pain sensors. Avoid spine manipulation, stretching and twisting exercises like the scorpion. What makes the pain worse? Specific triggers mean specific solutions. You may not need to eliminate activities like golf or basketball entirely. Just modify the movement patterns. Even slight spine flexion at the bottom of a squat triggers disc pain in sensitized individuals. And heavy breathing during basketball causes the spine to lose protective joint stiffness, which corrective breathing exercises can address. Is pain worst in the morning? Mattress stiffness matters. Those with large natural hollow in their lower back or prominent buttocks won't do well on a very firm mattress. A pillow top surface often helps. Avoid fetal sleeping positions that stress discs. Does pain increase throughout the day? Cumulative loading is exceeding your pain-free capacity. Just as an athlete interval trains to increase tolerable training volume, the back pain sufferer needs intervals between loading and rest. Does the pain radiate into your buttocks, legs, or feet? This almost always indicates trapped nerve roots, usually worsened by spine flexion that causes disc bulges to press on nerves. Better movement usually reduces it. Does fast or slow walking affect your pain? People with disc bulges often worsen with slow mall strolling, but improve with fast walking and arm swinging. Turning the pain mechanism into therapy. Stenosis sufferers experience cumulative pain buildup with any walking, requiring corrected technique and rest breaks. Step 2. Evaluate your lists. Compare your 2 lists with your answers to the essential questions. Do all pain-causing activities share a common spine posture, movement, or load type? Do pain-free activities share common features? These patterns are your diagnostic signal before moving to provocation testing. Step 3. Provocation and relieving tests. Sit on a stool and pull upward on the seat while maintaining a neutral spine. Then repeat while slouching, then with an arched back. This reveals whether compression, flexion, or extension triggers your pain. Add neck flexion and extension to each position. If neck flexion increases pain but extension reduces it, you likely have nerve tension pain from a bulging disc. For load testing, stand and drop on your heels. This creates roughly 1.5 times your body weight through your spine. If this triggers pain, test whether abdominal bracing eliminates it. If bracing worsens pain, try shoulder bracing instead, contracting your pectoral and latissimus muscles to pull your shoulders down and away from your ears. Then repeat the drop. To discover pain-relieving postures, lie on your stomach for 3 minutes when experiencing pain. Then stand without flexing the spine. If pain is reduced, you've likely confirmed a disc bulge. 3 minutes in that position has already slightly reduced it. If extension causes pain instead, try extension combined with rotation to each side. Then stand on one leg on the painful side and repeat. If the pain lessens, neutral spine becomes your feel-good position. For load testing with a 5-pound weight, hold it at your belt buckle in your pain-free posture, then extend your arms. If this triggers pain, your back is currently very load intolerant. Avoid unnecessary loading and postpone demanding activities until you're healthier. Personality type affects recovery. For type A people, hard driving and achievement-focused typically overdo prescribed exercises. Given 8 repetitions, they'll do 16, and they wonder why their back hasn't improved. They must give themselves permission to rest. Type B individuals do only 4 when asked to do 8, and make excuses to avoid the effort. Both extremes are equally problematic. Type A never gives the back adequate rest, and Type B never achieves the fitness needed to control posture and loads. Pain categories and when to seek help. Flexion-triggered pain, worsened by slouch sitting, bending, or tying shoes, almost always indicates a disc bulge and responds to tummy lying and hip hinging. Pain with dynamic loading suggests vertebral end plate compression. Abdominal or shoulder bracing helps. Pain after walking a specific distance, common in older individuals with arthritis, responds to interval training with relieving postures between sessions. Episodic back pain, interrupted by flare-ups, most likely involves the disc. Identifying and avoiding the specific trigger is the solution. For inconclusive results, keep a daily log linking activities to pain level. Competent clinician identifies your specific triggers, explains your condition's natural history and prognosis, prescribes specific movement and posture corrections, and delivers a comprehensive recovery plan with clear benchmarks. All back pain has traceable causes. The master clinician teaches you what yours are. If yours hasn't done that, find one who will. Removing the cause of pain. Learning basic movement tools. In this chapter, he shifts from diagnosis to action, offering a practical guide for incorporating pain-free movement into daily life. The central premise is that chronic back pain sufferers must move in the most spine-conserving way possible, and that requires sustained mental engagement. Once mindful awareness becomes habitual, pain-free movement eventually becomes automatic. Foundation is the abdominal brace. It's not the same as sucking in your stomach or pulling your navel toward your spine, a myth the author calls actively harmful, popularized by some physical therapy, Pilates, and fitness traditions. True bracing is a mild contraction, as if preparing to absorb a punch to the midsection. Think of it like a dimmer switch rather than an on-off toggle. More stiffness for heavy lifting, less for walking or rising from a chair. The goal is just enough bracing to eliminate the pain and no more. From there, he walks through pain-free postures for lying, sitting, and standing. For acute pain, the lying drill involves progressively propping the chin on one or two stacked vertical fists while lying on the stomach, breathing deeply to restore the lumbar curve. If 2 fists increases the pain, regress to 1 or none. The sitting correction involves rolling the pelvis forward and lifting the chest simultaneously, supported by a firm lumbar pad on a firm surface. Soft couch feels relieving, but it's deceptive. The same stretch reflex that makes knees to chest feel good is at work, while disc strain actually increases. For standing, the goal is relaxed back muscles and arms kept at the side. Crossed arms round the shoulders and unnecessarily load the back. He then introduces 3 core movement tools. The squat, a hip hinge pattern, handles sitting, rising, and lifting. Hips move back descending, forward ascending, spine neutral throughout. The lunge transitions the body from standing to the floor and back, essential for floor exercises and getting out of bed without pain. The stop twist prevents painful spinal rotation during everyday tasks, like opening doors or rolling over in bed. Mindful movement is not preparation for the real work. It is the work. Spine hygiene, expanding your pain-free abilities. Spine hygiene means keeping daily upkeep of your back, your recovery routine plus intentional changes to how you move throughout the entire day. The core principle is simple. Stop picking at the proverbial scab. Every time you allow a painful movement, you reset the healing process. This chapter walks through common daily activities and how to perform them safely. Sitting builds disc stress over time, so the author recommends a restoring drill every 20 minutes to decompress the spine before discomfort accumulates. Walking should involve arm swing and upright posture. Slouching and slow shuffling actually increases pain. For bending, the golfer's lift offers a hip hinge alternative that keeps the spine out of flexion. When pushing or pulling heavy objects, force should travel in a straight line directly toward or away from the navel, never through a spinal twist. He closes with a detailed checklist. Vary postures before pain starts. Prepare your spine before sneezes or lifts. Hold objects close to your body. Split heavy loads when possible. Avoid strenuous exertion immediately after prolonged sitting. Never bend or do sit-ups right after walking when discs are swollen. Stiffen your core, matching effort to task. Use momentum rather than slow lifting for heavy loads. And take rest breaks that are the mechanical opposite of your work task. The author's conclusion is direct. Years of harmful movement habits must be consciously replaced until pain-free patterns become automatic. Building a resilient back, the non-negotiable Big Three exercises. With pain triggers identified and daily movements modified, we now shift to active rehabilitation through what the author calls the Big Three exercises: the modified curl-up, the side bridge, and the bird dog. Research confirmed these three movements build muscular endurance and stability while sparing the spine from damaging micro-movements, and their protective effects can last several hours after each session. All three share a common structure. Holds begin at 10 seconds to reduce cramping risk, and repetitions follow a descending pyramid. Sets of 5, 3, then 1 rep to start. If pain prevents a single session, he suggests splitting it into 3 6-minute sessions across the day. He urges readers to become Type C, competent exerciser, who follows instructions consistently, avoiding both obsessive overtraining and passive undertraining. The modified curl-up is nothing like a standard crunch. Hands slide under the lower back to preserve the lumbar curve. One knee is bent, and only the head and shoulders lift slightly. The spine stays completely still, and he suggests imagining your head resting on a bathroom scale and making it read 0. The side bridge targets the quadratus lumborum while integrating the abdominal wall and latissimus dorsi in a spine-conserving way. Beginners start from the knees. Advanced versions progress to the elbow and feet support, eventually linking both sides through a brief forward plank hold between rolls. The bird dog raises the opposite arm and leg simultaneously from all fours, keeping limbs parallel to the floor. Research shows it spares the spine from compressive loads while actively desensitizing pain. A sweep the floor technique between holds and an advanced drawing squares variation increases challenge progressively. Research also found that people performing equal sets across all three exercises have a lower risk of future back disorders. The cat-camel complements the Big Three through gentle spinal motion, not stretching. Lab movements showed just 7 to 8 cycles reduced internal spinal friction, with additional repetitions offering no further benefit. The chapter closes by eliminating harmful exercises entirely. Knee to chest stretches, knee drops, and the Superman, which generates 6,000 newtons, roughly 1,300 pounds of compressive force on a hyperextended spine. You don't want to do that. The walking program, nature's back bomb. Walking is described as a natural back bomb, something reapplied throughout the day and a mandatory component of any pain elimination program. Scientifically, each step requires muscular activity to stabilize the pelvis, producing gentle, repeated contractions that challenge the lateral spine and core. The torso acts as an energy storage system with elastic tissues unloading the spine. Arm swing and faster pace amplify this effect through torso sling muscles. Counterintuitively, slow walking often worsens the pain by statically loading the spine, suppressing arm swing, and locking the knee in full extension, eliminating the spring action needed for pain-free movement. Brisk walking typically converts walking from a pain cause to a pain reliever. Pavel Tsatsoulin's observation is instructive. Americans tend to look downward and lead with the head, while Russians lead with the chest, naturally promoting arm swing. The Russian style is the therapeutic goal. Prescribed form includes upright posture, lightly stiffened abdominals, arms swinging from the shoulders, and deliberate brisk steps. For high-sensitivity patients, the program begins with 6 to 8 steps hourly, building toward 30 minutes 3 times daily. Mid-walk micro breaks allow posture resets. Progression includes inclines, backward uphill walking, and optional short jogs, followed by 5 days of rest. Patience, not pain tolerance, drives long-term success. The core program. This brings everything together into a daily maintenance routine designed to eliminate pain and preserve function. The author emphasizes that no exercise program works if poor movement habits persist throughout the day, making all-day spine hygiene non-negotiable. After 4 to 6 weeks, a typical person should reach cat-camels at 8 slow reps per set, bird dogs, curl-ups, and side bridges using a descending rep scheme, 6 reps, then 4, then 2, with 10-second holds and 30-second rests between the sets. Walking adds 30 minutes before work, 20 at lunch, and 30 after dinner. Those with low tolerance should spread several short sessions throughout the day. To progress, add 1 repetition per set rather than extending hold times, preventing cramping while building endurance. Form always takes priority over volume. Restoring the hips. In this chapter, he explains that back pain inhibits the gluteal muscles, creating a cycle of worsening hip and back pain. But attempting to fix hip deficiencies too early only causes more frustration. Let pain sensitivity settle first and avoid premature hamstring or hip stretching. Stiff hips transfer excess motion to the spine. The hip airplane drill is recommended as a mobilizing exercise. It's not a stretch. Back pain also tightens the psoas along the front of the hip and spine. To reintegrate inhibited glutes, clamshell exercises and back bridges are the best documented option. On deep squatting, children squat deeply because of proportionally shorter legs, not superior mobility. As adults, hip sockets deepen for load-bearing stability, risking anterior femoral impingement. Body weight squatting once daily is sufficient and won't aggravate pain. Next level training, regaining your active lifestyle. This chapter addresses readers who want to move beyond pain relief and reclaim genuine athletic ability, whether shooting hoops, dancing, or cycling with friends. For those satisfied with reduced pain, the advice is simple. Keep doing the big 3 and practicing spine hygiene daily, because returning to old movement patterns risks relapse. For those pushing further, the author introduces resistant training organized around movement patterns, pushes, pulls, lifts, and carries, rather than isolating individual muscles. Exercises progress in a specific order: sagittal plane first, then frontal plane, then anti-rotational challenges. Critically, the spine is never actually twisted. The goal is always to resist twisting forces while maintaining neutral position. Weighted single-arm cable pulls, for example, impose far greater spinal loads than other planes. 2 starter exercises anchor the program: push-ups for the anterior chain and suspension strap pulls for the posterior chain. Rope pulling builds grip strength, which ultimately spares the back. The non-negotiable rule throughout: never sacrifice form for more load. Considerations for special conditions. While diagnostic labels for back pain have limited usefulness, certain conditions do warrant specific treatment approaches. The author emphasizes consulting your physician before beginning any exercises, particularly to rule out underlying medical conditions. Sciatica refers to pain traveling along the sciatic nerve from the lowest lumbar joints through the buttocks, hip, back of the thigh, and down to the foot and toes. Where toe pain appears reveals which nerve root is irritated. Big toe pain indicates L5, while the 4 smaller toes point to L4. The author has treated patients with severe foot pain where doctors suggested amputation, only to discover the true source was a pinched sciatic nerve in the lumbar spine. Despite where the pain appears, the origin is always compression in the lumbar spine itself. Treatment focuses on removing the cause, not just the symptom. Contrary to popular belief, stretching an irritated sciatic nerve increases its sensitivity, yet many mistakenly treat sciatica by stretching their hamstrings. Instead, the author recommends nerve flossing, moving the nerve through its canals without tensioning it, like dental floss gliding between teeth. Sitting where legs can swing freely, you coordinate neck and knee movements. Extend the neck while extending one knee with the foot flexed upward, then reverse by flexing the neck while bending the knee and ankle. Each cycle takes 3 or 4 seconds. Some patients find relief within days, others need several weeks. Timing matters. If symptoms are worse in the morning, floss later in the day, and vice versa. For disc-related sciatica, lying face down supporting the chin with fists for 3 minutes before flossing can reduce the bulge and improve results. For arthritis-driven sciatica, the author uses modified interval walking. Find a posture that reduces radiating symptoms. Walk until symptoms just begin, then decompress using wall walking or a park bench, and repeat the cycle. This turns painful walking into therapy. Stenosis, narrowing of the spinal canals, commonly develops with age and progressively limits walking distance before pain sets in. Many therapists recommend spinal flexion, but this frequently backfires because flexion increases spinal loading. Extension drills combined with interval walking, park bench decompression, and the big 3 exercises prove far more effective. Notably, traction is the only therapy shown to be broadly effective for this group. Thoracic kyphosis, or upper back rounding, affects aging adults, former runners, and younger people hunched over screens. Daily corrective stretching restores your natural upper spine length. Mid-back pain often stems from a chest poker pattern. The Lewitt exercise corrects this. In a crook-lying position, breathe out forcefully through pursed lips to expel air, activating the abdominal wall and pulling the chest down. Repeat 3 to 4 cycles. Scoliosis can sometimes be corrected through exercise. If hanging from a bar visibly reduces the curve, corrective exercise may help. The Schroth method, opening the concave side through active stretching and breathing, has helped many patients. Claudication, often mistaken for stenosis, results from reduced arterial blood flow starving leg muscles of oxygen. Interval walking is the primary treatment, with some cardiology associations recommending up to 60 minutes of intervals 3 to 5 times weekly. Older adults benefit from fall prevention through single leg balance work and hip strengthening. A successful aging program includes daily joint sparing movement, twice weekly strength training, twice weekly novel activities, and 3 times weekly mobility work. Overweight patients rarely show spinal instability. Their girth naturally stabilizes their spine, so treatment emphasizes endurance and mobility quality, paired with meaningful weight reduction. Solutions that solve back pain, case studies, and sample programs. The core exercise program in this book isn't one size fits all. It has to be modified to fit each person's limitations while avoiding their specific pain triggers. Most people carry traits from several back pain categories at once. The typical recovery arc follows a recognizable pattern. Eliminate pain triggers, build the big 3 into your daily routine, gradually expand your pain-free repertoire, then add more challenging movements as your ability improves. At that point, people often get overzealous, try something new, and wake up in pain. These setbacks are lessons. When progress stalls, regress to a lesser challenge that worked before. You'll regain ground faster and won't start from zero. Matt's morning stiffness. Matt awakes with back stiffness so severe that putting on socks is a struggle. The typical advice is to stretch, pulling knees to chest. Stop immediately. That stretch triggers temporary reflex relief lasting about 15 minutes, but guarantees the stiffness returns tomorrow. People with pronounced lumbar curves experience pain lying on their back because their spine becomes suspended like the middle of a bridge, pushing into flexion. Choose a firm mattress with a quality foam topper. After rising, avoid spine flexion, walk before sitting, do cat-camel cycles without pushing to end range. Then perform the big 3 later in the morning. Pamela's escalating pain. Pamela wakes with minimal pain but accumulates increasing back pain throughout a busy day of work, parenting, and half-marathon training. This signals that cumulative spinal loading exceeds her pain-free tolerance. The solution isn't to push through, it's to remove offending motions, shorten task durations, and introduce frequent spine unloading rest breaks. Symptoms typically wind down within days. Alicia's type A overexertion. When given 10 repetitions, Alicia does 20, convinced more effort means faster recovery. The author recommends the virtual surgery game. Pretend you had surgery today and tomorrow begins recovery, complete rest. Surgery often works initially precisely because it forces rest. This reframe delivers a win by removing all loading and giving overstretched tissue time to heal. Brad's type B avoidance. Brad, 55, sits at a desk all day and spends evenings reclined on a sofa. When given 10 repetitions, he stops at 3. The author is blunt. Brad can avoid exercise and live a painful sedentary life 24 hours a day, or dedicate at least 1 hour daily to training and improve the other 23. Some people keep seeking easy cures and almost always remain pained and fragile. Dave's driving pain. Dave, a truck driver, notices back and leg pain increasing with driving duration. Don't keep wallets in the back pocket or drive long stretches without breaks. Adjust the seat to support neutral posture and recline slightly to reduce flexion pressure. During breaks, practice the standing McGill stretch, then walk briskly before returning to the vehicle. Penny's misdiagnosed nerve pain. Penny's pain traces from her hip through the posterior buttocks down to her toes, commonly misdiagnosed as piriformis syndrome, which is actually rare. The real source is usually lumbar nerve root irritation. Big toe pain indicates L5 involvement. Other toes point to L4. Stretching makes this worse by increasing nerve sensitivity. Instead, move in spine-sparing ways. Use lumbar support when sitting. Let sensitivity wind down naturally. Octavio the opera singer. Octavia had a flexion-intolerant disc and tried to solve it through strength training. The resulting torso stiffness radiated into his shoulders and neck, inhibiting his breathing and vocal power. Worse, breath holding during training caused his diaphragm to open his esophageal sphincter, leading to nighttime acid reflux that damaged his voice. The lesson? Core bracing must be tuned to the individual. Octavio needed to stiffen his lower torso while relaxing his upper torso with each breath. Side planks with deep breathing helped ingrain this pattern. Samina and Sadie. Different stenosis, different solutions. Both women had stenosis, causing hunched posture and radiating leg pain, but different causes required different treatments. Samina, 76, had arthritic bone narrowing her nerve canals. Corrected walking with purposeful arm swings, stopping before symptoms appear, combined with a walk-walk recovery drill between intervals, helped restore tolerable walking. Sadie, 48, had stenosis from a disc bulge caused by specific movements. Eliminating those patterns allows the bulge to reabsorb. The principle, stenosis treatment, depends entirely on its cause. The bizarre cases. Some patients dismissed as psychological had real diagnosable problems missed by non-experts. One allodynia patient couldn't bear a bedsheet on his toes. One doctor suggested amputation. A lumbar nerve trap from a disc bulge was identified and released through flossing and spine hygiene. He is fully recovered today. For fibromyalgic patients, the most effective approach uses gait theory. Teaching pain-free movements floods the proprioceptive system with joint and muscle signals, crowding out pain signals. Repeating these movements encodes new patterns in the brain, slowly expanding the patient's pain-free repertoire until normal function returns. The through line across every case is this. All of these patients had consulted spine experts and failed to find relief. Having worked through this material, you are now the back mechanic, equipped to perceive your pain, understand its cause, and find the strategies that actually work. Q&A time with the back. Sex, selecting a mattress, and other things you're afraid to ask. This final chapter compiles the most interesting and commonly asked questions from doctors, patients, and athletes. One truth remains central. No one else will fix your back for you. You must be an active participant in your own healing. Ergonomics and job coaching. Ergonomic design helps in controlled settings like assembly lines, particularly for older workers with stiffer hips. But jobs like forestry, construction, and fishing cannot be fully redesigned. The author developed job coaching, combined ergonomic optimization with training workers to move in spine-friendly ways. Both elements must work together. Spine hygiene as a way of life. Spine hygiene means sparing your back in every daily activity, accomplishing two things: longer, pain-free periods and greater capacity to tolerate therapeutic exercise. A simple illustration is shoe tying. Instead of flexing your spine while seated, place your foot on a chair and lunge forward with an upright torso, letting your hips close the distance. Back health requires constant movement awareness throughout every ordinary task. Travel considerations. Airplane seats are built with a hollow in the lumbar region, the opposite of proper support. No kidding. The author's lab studied spine stresses from airplane seats and couldn't determine why they seemed designed to damage backs. The solution is carry a lumbar pad, standing and walking the aisles periodically, and exaggerating the lumbar lordosis while seated. Upon arrival, walk around before retrieving luggage. Different hotel beds offer an opportunity to experiment with firmness. If you wake less stiff, note the make and model of the mattress. Mattress and pillow selection. Research shows individual variation based on spine characteristics. Cultures sleeping on futons tend to have flatter backs with less lordosis and tolerate firm surface as well. Curvier bodies with defined hips and shoulders do better with a firm foundation and a cushioned top. Heavier people with less defined curves prefer firmer beds overall. Pillow selection depends on sleeping position. Back sleepers may benefit from dedicated lumbar support. What about back belts? Key findings from the author's lab: those without previous back injury gain no protective benefit from belts. Those injured while wearing belts risk more severe injury. Belts give people the perception they can lift more and often enable them to through elastic recoil, and habitual belt wearers face higher injury risks when they suddenly stop. Athletes attempting maximum lifts should wear belts. Those simply wanting better back health should avoid them. The author wrote belt-wearing policies for several governments in the early 1990s and concluded that company-wide mandates are not justifiable. For individuals who do benefit temporarily, policy required 5 steps: an ergonomic job assessment, mandatory spine-sparing education, cardiovascular health exam, back assessment identifying movement flaws, and commitment to a therapeutic exercise program to develop the body's natural anatomic belt. Stretching. Early in recovery, bending stretches often cause more trouble than they cure. Counterintuitively, people with greater spine flexibility are at higher risk for future back pain. Temporary relief from stretching comes from stimulating the stretch reflex, a fleeting mask of underlying damage. Stretching also creates trade-offs. Practicing yoga for mobility will compromise the stiffness needed for heavy lifting. It must have a specific justified purpose and should come later in recovery. Sex, passive therapies, and final principles. Regarding sex, bend through the hips, not the spine. If you're on top, use the hips. But on the bottom, support the spine's natural curves and avoid initiating movement. Passive therapies, ultrasound, massage, manipulation may temporarily reduce pain, but don't address underlying causes. Studies support only 1 to 3 manipulations for acute disc bulges. Seek practitioners offering active care. If an acute attack feels imminent, lying on your stomach with one fist under your chin can reverse an impending disc bulge. Finally, ignore promises of easy steps to eliminate back pain. Understanding your personal pain triggers is essential, and that honesty is itself the most useful thing this book can offer. Final chapter serves as a send-off and reminder of what the reader now holds, a practical owner's manual for the spine. The author's closing advice centers on balance. He recommends keeping a journal during recovery, not to track pain levels, but to log daily activities and identify what helped or hurt. He cautions against 2 equal dangers: losing motivation and slipping into old habits, or pushing too hard on pain-free days and triggering a setback the next. For readers wanting deeper material, he points to his more advanced books on low back pain disorders and athletic performance. His final practical tip: bring this book to physician appointments to ensure shared language and aligned thinking. Closing message is simple: a well-informed patient is always their own best advocate, and don't forget to smile. So that brings us to the end of this episode of the InnoGuide podcast. I hope these ideas encourage you to think differently about back pain, not simply as something that inevitably comes with age, but as a problem that can often be better understood by identifying the movements, positions, and habits that are placing stress on your spine. We spend a great deal of time thinking about how to improve our tools, our systems, and the way we work, but our body is the system that supports everything we do. If sitting, lifting, exercising, or even the way we move throughout the day is gradually causing damage, it will eventually affect our ability to lead, create, solve problems, and perform at our best. The goal is not to avoid movement or live in fear of injury, but to better understand how your own back responds, remove the activities that repeatedly aggravate it, and build the strength and movement habits that allow it to heal and remain resilient. The Back Mechanic is a book you may not fully appreciate till the day you need it, but when that day comes, having a practical resource that helps you ask better questions and make more informed decisions can be enormously valuable. You can find more podcast episodes, articles, and resources, and information about how I help teams work smarter and put AI to practical use at innoguide.net. Until next time, keep learning, keep questioning, and take care of the system that carries you through every day. And always stay curious. I want to thank Steve McIntyre for producing this episode, and I especially want to thank you for joining us. That's a wrap.